Okay, going to the ward. Yeah, okay. I'll do a recording from here. Okay. Okay. Going to the ward to see a case, okay? So when you enter the patient's area or room, for instance, okay? So first thing is you make sure the patient is there and check it's the same patient, okay? That you're supposed to look at, huh? Okay? And then you don't go straight onto the bed and look at the patient, okay? You look around, okay? Make it a habit of helicopter view, huh? Before you land on the patient. So what would you be looking at around the patient that will give you an idea what is wrong with this patient? Okay.
For example, if the patient has anything on the table, like asthma, the puffler.
Okay. Okay, good. So you look at the, okay, so first of all, maybe I need to know where am I, okay? Is this in the A&E? Is this in the ICU? Is this in the postmortem? Or is it in the general ward, isolation ward? Where is the patient? Because if you know where the patient is, open ward, closed ward, isolation ward, COVID ward, then you know roughly which area to a little bit zoom into. Okay. So which ward? Okay, first, and then when you go into the room, then you can look at the. You want to look around the furniture first. Is it okay? So you're looking at the tabletop and looking for all the things which may be related to the sputum cup. You know, for adults, the bedpan, you know, and yeah, and the wheelchair, you know, tongkat, whatever, that will help you to give you an idea of the, okay, and then, so around the, what else could be around the patient's bed that you need to notice?
Maybe there's like any like respirators or oxygen mask on the patient, or if the patient is have a catheter and like a urine bag.
Okay, so what you do is, I still want to look at furniture first, okay? So besides the things on the patient's medications on the table, then there are other big things which may be there, which could be ventilator, okay? Which could be a drip, and measuring devices, and sometimes all the monitors, okay? All right? So these are all extra equipment around the patient, which will give you an idea that the patient is relatively ill, okay, outside. Okay, so equipment around and what the patient's medications is around the table. Okay? Then you look at the around there, oxygen and the oxygen outlets, okay? All right? The wall oxygen. So the wall oxygen, are they on or off? And automatically, the moment you see that it's on, bubbling, yeah, then you need to look at how fast. So make it an automatic. So when you look at a girl, you go look at certain features. So oxygen, when it's running or not, and then how fast it's running. Okay. And how do you decide how fast is the, have you seen all this oxygen? No, huh? Okay. So usually there's a ball bearing on the, it's, you know, a ball bearing sort of floating. So usually we look at the middle, the equator of it. At not the top of the ball, but the equator of it, as the speed. So 5 liters or 2 liters or whatever. Okay. And then so okay. All right. Then only then you look at the patient. Of course, hopefully not died yet, but anyway, the patient. Then you have to see how the patient is. Is it lying flat? Is the patient up? Prop up? Is it like you know, like they have a cardiac bed and they are prop up 45? Or the bed of the end of the bed is up. Like in some of the shock cases, sometimes the bed is raised, so we know, oh my God, the blood pressure must be going somewhere. Yeah, and so on. So the position of the patient, how they are lying, or if they are just sitting there and waving at you like the children or jumping up and down, you know, it's probably on the way out already. Yeah? So it's very useful. Yeah. So then you look at the tubes in and out. Tubes in and out. Okay. So of course, now tubes in, you already saw the oxygen. So automatically your eye will follow through to the end to see where the oxygen can go, okay? So where can the oxygen be delivered to a patient? How can the oxygen be delivered? Have you seen patients on oxygen? No, on TV also they don't show. It's too yuck. So again, the tubes, you have to see where the tube goes. So starting with outside, so in pediatric ward, we talk about the head box in an incubator. So we have head boxes. So the oxygen is actually goes into the head box. So the child is breathing a little bit higher oxygen, not that high, but higher head box. And then of course the tube can go to the nose as a nasal catheter, or it can go deeper into the nasopharynx, nasopharyngeal for CPAP usually, or there can be a long tube going into the trachea, which is the intubation, that which usually there is a ventilator already. But if it's just oxygen from the wall and it's going direct to the patient, then you're usually looking at head box, face mask, some sort of face mask in adults, usually ventral, some sort of face mask, or tubes that goes directly into the nose. And by the time it goes either in the mouth or the throat and goes deep, you know that usually it's connected to the ventilator, not to the wall. Okay, all right. So one tube in is oxygen. Now the next tube in will be
nasogastric tube.
Yes, NG tube that goes into the stomach. Yeah, usually in children, sometimes we go through the nose, sometimes mostly actually usually in the mouth. Okay, NG tube. And so as an automatic thing, then you look at the end of the tube coming out and you must check where it's going, okay? Okay, sometimes it's just plugged on, it's plugged on for feeding. Usually feeding tube, we don't put into a bag, you know. But in some cases, you may see that it goes into a collecting bag of some sort, okay? Which means in adult patient post-operative and all that, sometimes they have a NG tube, which is actually not for feeding, but for removing, you know, whatever things, you know. And so automatically your eye will go to the end of it and see what is in that. Okay? So in that bag, what type of things can you see?
Waste products.
Clear, colorless, mixed blood. So you have a tube coming out from the catheter, urine catheter coming out, and there's a urine bag. Okay, there's a urine bag. Automatically, your eyes will go to the content, and you ask yourself, clear, cloudy, blood stain, pus, blood, urine, or any bag that comes out anywhere. So from now on, any tubes coming out from whatever patient, in medical work, you've got tons of tubes everywhere. You start from the head going down, okay? So NG for breathing, and then for feeding or aspirate, you know, and then other tubes from parts of the chest wall, abdomen, bladder, kidney, but all of them will be connected to something, and automatically your brain will say, clear, colorless is not there already, but anyway, it's a clear, cloudy, blood stain, or others, rubbish, stomach on. Okay. So all the tubes coming out, and now I want you to look at tubes going in. Just now we talked about oxygen. Then the other thing that comes in will be the IV lines. Okay. So automatically go to the IV, IV line first. How it is done. So if you, I just talked about it now. Is there a pump? Okay, or there are some type of pumps, or is it just hanging and dripping? Okay, or is there a pump? Okay, if there's a pump, always look at the rate and wonder why there's a pump. Okay, syringe or pump. If it's just free running, then you always count as a habit, half a minute, see whether the drops are moving. Okay, half a minute. Yeah, because it's always somehow or other, sometimes the things get blocked, and then sometimes you can actually help as a medical student. When things don't seem to be moving, at least you can check for the patient. So how would you check if you see that there's a drip and there's no drop? So how? Should be dripping, right? Okay, so what is the differential diagnosis?
The tube is blocked.
Okay, now we talk about tubes that are blocked. That's the recipe I forgot, right? Okay, tubes. I think Hon is having his aha moment. So tell me about the tubes that are blocked. Okay, starting from
Inside to
inside
outside.
out. Okay.
So inside, so first of all, it might be blocked inside by any kind of things.
Mm.
So
IV lines blocked means
means
from inside would be maybe clotted or some blood clot or something. Yeah. Okay. All right. So okay, one. Then
at the middle, maybe like there are some like structural deficits of the tube.
kinking, or okay, or the patient may in children could be just so it could have come out anyway the tube, but usually if it come out, then usually the thing will still be running, but it will be quite weird because yeah. So sometimes the tube is out, but it's still running, but the rate is out and it is weird. Okay, so and the whole thing will be very wet and stuff. So okay, so tubes. So inside is foreign bodies or whatever blocking inside. Then tubing structurally can be kinked, I guess. I guess king. Sometimes they just so certain you just position and they're okay. Then pressure from whatever. So sometimes the bandages or the patient may be sitting on it or something is on it. So sometimes external pressure, right? Tubes. Yeah, I think that's the three main. So always help the nurses to count and then check. So change position, check position, see whether the thing is swollen or whether the thing has come out, or whether actually the it's off. Actually, supposed to be off, but somebody has no time to go and remove so they may actually have stopped it. External, there's a little IV, huh? Okay. So IV lines also, when you're looking at the IV, immediately your brain say, what fluid? Okay, what fluid? So IV fluids, huh? Have you learned about IV fluids?
Not in detail.
Not in detail. So give me the differential. If you look at someone is on an IV line, if something is hanging there, and then how would you decide?
So maybe you have to see what is the patient suffering from.
No, wait. Just you don't know the patient at all, right? You're just going. Okay, IV line with a bag there. Give me a differential.
You can first see if it's clear or
good. So you go into that same list. Okay, clear, cloudy, blood, or blood products. Okay, right? So the clear, colorless ones will be all mixtures of water with salt, potassium, glucose, or dextrose, bicarbonate, lactate, whatever. Okay, mixtures, different proportion in different wards for different situations. So it vary from 10% dextrose to 5% dextrose to plus saline plus. So it okay, colorless, clear and colors, IV. Blood, then you talk about full blood or packed cells, okay, and then blood products, then plasma, immunoglobulin, blah, 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 okay. In between some colored solutions, sometimes then you talk about drugs, vitamins, nutritionals, okay. Can you repeat? Repeat for me the fluids, IV fluids. When you see a patient with the IV line, and automatically you look at the bottle. So
we look at the fluid, is it clear, cloudy, or any blood product?
Or colored. You can put color there now.
For the clear one, it might be some saline.
You just say it's a mixture. Any mixture of water, saline, water, salt, and potassium bicarbonate. Just go down that list, okay? Yeah.
And the colored one might be some vitamins. And the red one, blood product, like plasma. or full blood?
So blood under blood is packed cell, not packed cell. Start with full blood, whole blood. We call it whole blood, huh? And then you take away the plasma. You pack it down. It's packed cells. Okay. So you see a bag of blood. Usually it's either packed cells or full whole blood. Then you look at the colored, plain, color and cloudy and so on solutions in some sort of blood packing. Then you think of plasma. Okay. And then small bottles with different cloudy also looks a bit colored here and there. Sometimes you look at maybe it's immunoglobulins or some of these weird things, okay? And then the color solution, which is clear, then you talk about maybe vitamins, nutrition, okay? Okay, so I don't even allow you to jump on the patient yet, okay? That's why pediatricians, we are very, I don't know, I mean, we are super hyper actually, basically, but we don't apologize for it, okay? Because the last thing we want you to do is to upset the patient and the parent, and then your students will be banned. You know, like in UK when I was training, and they look at us, even postgraduate, patient is sleeping, and end of story. We get no chance. So if you are very, you make them cry, end of story. So actually, a lot of things you can actually already decide. By the time you look at the patient, okay, then one of the last things I will look at is temperature chart. And temperature chart, that's where I look at the name, make sure it's patient is, the same name, same age. No, age, 7 years old, but this fat guy is like, oh my God, wrong bed, double check, that's where the age part of it will come in, a little bit of assessment there. The temperature chart is very useful. So you look at temperature chart, the blood pressure, and then if the monitors, then automatically look at the monitor, the blood pressure, heart rate, ECG, whatever. Okay. So I make a bit of difference on the way you approach any case from now on. 5 of you, I challenge you. When you say, hey, come and see this very interesting case, like whatever of cystic fibrosis, whatever crazy things. You stand back and say, okay, practice. Okay. Looking at the environment first. So where? Okay, let's revise. Okay. Okay, Ian. Call to see a patient. Okay, then first thing you ask is?
See where I am at the moment.
Where is the patient? Where you are at the moment, I don't care. I don't care if it's a wedding anniversary or end of story. The consultant's voice at the other side, end of story. Okay, I don't care where you are. All I care is, first of all, where the patient is. Okay, you want to go? Where is the patient? Okay, so where is the patient? Because you want to know
if the patient has any special needs, or if the patient, like where the patient generally is, if it's in a general ward or ICU or A&E or any special specialist clinic.
Okay, good. So that's one. Where? Okay, where the patient. Then
next we can go into the ward, and then we can look around and see around the patient's the furniture of the patient.
Okay, maybe you say, this is the patient, then check the name at the door. Make sure it's the same person. Okay, all right. Then when you enter the door, then the first thing you make it a habit of a helicopter view. I call it a helicopter view. Okay, you can start from the walls and go to the furniture and the bed. I think that's easier, huh? Right? You go around the wall, and then the other things around the bed, and then the bed. Okay, or you can start with the bed and then look the furniture also can. Okay. So where do you want to start?
I'll start outside in. So
okay.
I'll look around the patient first, like to the furniture around the patient, see if there are any medications or any of their relatives are around, or you can see if the patient is actually sleeping or not, or is awake. And then from there we go on to other things that may be around the patient, like the monitors, or if there are any like ventilators around the patient. Then
equipment.
Moving closer into the patient, you can see how the bed is positioned.
Wall first.
You can look at the wall, see if you can look at the oxygen flow, so we can see how fast oxygen is flowing. Then
is the patient on oxygen?
And after that, we look at the patient. So look at the bed, so see see if the bed is inclined in any way or not. If it's
Position of patient. Special bed.
Then moving on, we can look at the patient himself or herself. So we can look if the patient has any tubes that's connected onto the patient, for example.
So tubes going in and tubes going out. Okay, starting from the head. Okay.
So starting from the head, there may be like oxygen.
Tubes going in first.
Okay, tubes going in. So firstly, it can be an oxygen tube, either a face mask or just an oxygen tube.
Head box first.
Oh, yeah, sure. For
kids,
children, they
yeah.
can be like incubation tubes or head boxes for the patient.
Head box, mask, nasal cannula, nasal tubes, nasopharyngeal tubes, intubation tubes.
Then from there, there can be other tubes going in, like a nasogastric tubes.
Yes. Oral gastric or nasogastric tubes, and then they can be in or out. Okay, the ones that are have things going out, they will be attached to some sort of bag. They will not be plugged up. Okay, if they're plugged up in Pittsburgh, sometimes we plug them up because we don't want the head, so we plug them up. But usually, if you see the loosely, there's a bag attached to it, and it's out, usually out rather than in. Okay, all right. So feeding tube or out. Okay.
For tubes going in, we can look at IV tubes as well. Or
IV lines, yes.
And then from IV lines, if we trace back, we see what the patient is actually receiving from the IV lines.
Okay.
So from there, we can look at what solution it is, or the color of the solution, clear or other. And moving on, we can look at any other tubes that is exiting the patient, either like a catheter or like an NG tube that is exiting. Then we can trace it to the bag itself again and see what are the things that are coming out.
So the basic principle is always start from the head and down. So starting from the head, the tubes that are potentially could be there, will be from the brain. Okay, could be the ventricular, peritoneal or ventricular shunt thinking. You can see. Okay, and then in the mouth, and then in the chest, the back, kidneys area. The drains, okay, could be at the back. And then the tummy, all the drains coming out, and urine. Okay. So for the IV lines, I'd like you to actually look at the IV, go and follow right through to the end. Okay. So when at the end, it's power line, you always ask the patient, is there pain? Okay, I ask you to look at the rate of flow, isn't it? So if it's flowing quite fast, and then you see look for swelling and then ask for pain. If the patient complains is painful, that means something is either displaced or lodged or So you must always worry about it. Okay. Okay, I think that should be quite useful for. That is more for housemaids.